Hello, class. My name is Cornelia Hobbengoff, and I am here to introduce you to the Ravioli Alveoli group, who will be lecturing you on the overweight and obesity. Okay, so here we go. Give a round of applause to the Ravioli Alveoli. Wow, thank you, Cornelia. Hello, everyone. It's me, Grace. I'm going to start us off with some definitions and diagnostic tools. So, obesity is an excessive accumulation of fat in the body that contributes to numerous chronic diseases, as we all know. So, a BMI at or above 30 is considered obese, and then overweight would be a BMI equal to or greater than 25. And then above 40 would be considered morbid obesity. And then diagnostic tool-wise, BMI is commonly used, obviously, and then waist circumference and waist to hip ratio, just comparing to norms with those. Pathophysiology. So your development of obesity will depend on an imbalance between energy intake and expenditure. So obviously, if you're taking in more energy than you're expending, you're going to gain some weight. So inactivity and an energy-dense diet are known contributors, with an energy-dense diet being a calorie-dense diet rather than a nutritious dense diet. So environmental factors that are coming up here are going to be lack of access to full-service grocery stores. So, some people have grocery stores near them, but they may not have all of those fresh produce options. They may just be kind of like a quick stop kind of mart thing. And so obviously you're not going to find the best foods there. And then increasing costs of healthy foods and the lower cost of unhealthy foods. I mean, classic example, hashtag McDonald's. I want McDonald's all the time. It's so cheap, it's so good, but it's so bad for you. So everyone is kind of dealing with those temptations of trying to get cheaper food. And then just a lack of access to safe places to play and exercise. Not everyone is going to buy a gym membership, and that's just what's going to happen. That's how it is. And then you have your chemical mediators and neurochemical pathways that will control your food intake and energy expenditure and your satiety. So, next. Theories of central nervous system, regulation of food intake. So if you have any genetic mutations going on, they can cause disrupted food intake and body weight control issues. And then there's this little thing called leptin, which is a protein that's secreted by your fat cells, and it actually switches off your appetite like a light switch. So if you have too much of this leptin, not too much, too little of this leptin, or if your receptors are less sensitive or they're resisting the leptin, then you're going to have an increased appetite. And obviously, if you're super hungry all the time, you're going to gain some weight. There are also other theories, but this was one of the main ones that we found. Risk factors. I'm not going to read every single one of these. Obviously, sedentary lifestyle, any other kinds of illnesses can cause you to, have a sedentary lifestyle, and then therefore you can become obese. And then you have you have a lot of medications that can lead to obesity as well, with corticosteroids being one, considering they cause your body to lose the inability to absorb glucose as well, which leads to fat deposits, therefore obesity. And then your antihypertensives, they fatigue you. So obviously if you're feeling tired a lot, you're not going to want to participate in physical activity. And then psychosocial factors are also important to think about too, because anything like sexual abuse or socioeconomic status that can lead to mental issues can also just cause lifestyle choices that lead to obesity. And then clinical manifestations, once again, not going to read all of these, but I think it's just important to note the extensive list here of things that can happen just by being overweight, and they can lead to a shorter and honestly unhappier life. So take that in, breathe it.
So now we're going to talk a little bit about the epidemiology. Obesity is a pandemic. There are about 300 million people affected worldwide. And here in the United States, it's actually the second leading cause of preventable death, and it contributes to 500,000 deaths annually. 65% of adults in the U.S. are categorized as overweight or obese, and between the years of 1980 and 2002, obesity doubled in adults and overweight prevalence tripled in children and adolescents. This graph shows the self-reported obesity prevalence in the US among adults. About 35% or more adults had obesity in 7 of the states, and a lot of these, as you can see, are congregated in the Southeast. So here you can see how education and age impact obesity. As the level of education goes up, obesity rates go down. Then obesity rates are the highest among middle-aged adults. As far as race goes, non-Hispanic blacks have the highest prevalence of self-reported obesity, and it's upward towards 40%. That's followed by Hispanics and non-Hispanic whites. With a socioeconomic status, obesity prevalence is highest among men in the middle income group. With non-Hispanic black men, obesity is highest in the highest income group. And then with women, obesity prevalence is lowest in the highest income group. And non-Hispanic black women, there are no difference. With childhood obesity, it's definitely becoming an increasing problem, as we all are aware of. About 10.4% of children between the ages of 2 and 5 are considered obese. 20% of children between 6 and 11 are obese, and that is a 147% increase from the years of 1971 to 1994, and I can only imagine what it's like now. That's crazy. And about 18% of people between the ages of 12 and 29 are obese.
Now we're going to talk about the medical management for overweight and obesity. There are 4 different types of surgeries for obesity, and these include the gastric bypass surgery, which is also known as the Roux-en-Y gastric bypass, the sleeve gastrectomy, which is also known as the sleeve, the adjustable gastric band, which is also known as the band, and the biliopancreatic diversion with duodenal switch gastric bypass surgery. Along with surgeries, there are also medications that are utilized for weight loss, and we will discuss these more in detail in the following slides. So the first surgery we're going to talk about is the gastric bypass surgery. This surgery is considered the gold standard of weight loss surgeries. This surgery contains 2 components. First, they create a small pouch about 1 ounce in size from the stomach by separating the rest of the stomach from it. Second, the first portion of the small intestine is divided in half, and the bottom end is brought up to the newly created stomach pouch, and the top end is attached to the small intestine further down the bottom end. And this allows for the stomach acid and digestive enzymes to bypass the stomach and the first portion of the small intestine. So the surgery works for many reasons. The new stomach pouch is smaller, so you have less caloric intake. There's less digestion of food, so you have less calories and fat being absorbed into the body. And this also changes the gut hormones to promote satiety, suppress hunger, and reverse the primary mechanism behind type 2 diabetes. The advantages include weight loss, food restriction, energy expenditure is increased, and disadvantages include a longer procedure compared to other surgeries, long-term vitamin and mineral deficiencies, and this also requires long-term diet restriction, supplementation, and follow-up appointments. So similar to the typical gastric bypass surgery, the biliopancreatic diversion with duodenal switch gastric bypass surgery is very similar, and it's considered to be the most effective for the treatment of diabetes. So this one also has 2 components, and first, a small tubular stomach pouch is created by removing a large portion of the stomach, and next, a large portion of the small intestine, about 75%, is bypassed by dividing the small intestine and cutting the duodenum off just past the stomach outlet. So the bottom end of the small intestine is brought up and connected to the new stomach pouch at the newly opened outlet, and the top end is attached to the small intestine further down the bottom end, and the duodenum remains connected to the pancreas and gallbladder, so the pancreatic enzymes and bile enter the intestine further down. This allows for pancreatic enzymes and bile to bypass the food, so absorption of protein and fat is decreased. So the surgery works for several reasons, and again, it's similar to the gastric bypass that we just talked about. So the new stomach pouch is smaller, so you have less caloric intake, you have less digestion of food, so less protein, fat, vitamins, and minerals are absorbed, And this also changes the gut hormones to promote satiety, suppress hunger, and this also controls blood sugar levels. The advantages include weight loss, reduced fat absorption, and it's most effective against diabetes. But the disadvantages include high complication rates, and it requires a long hospital stay, and you have potential for long-term deficiencies of proteins, vitamins, and minerals. So the sleeve gastrectomy is a one-step surgical procedure that is performed by removing about 80% of the stomach and leaving a pouch that resembles a banana. And this procedure works for many reasons. The new stomach pouch holds less food to reduce caloric intake. The surgery alters gut hormones to impact hunger, satiety, and control blood sugar. And studies have shown that this procedure is just as effective as the gastric bypass surgery in terms of weight loss and improvement or remission of diabetes. The advantages for this surgery include rapid weight loss, you don't have a bypass surgery involved, and this has a short hospital stay since the surgery is less involved. Disadvantages include a non-reversible procedure that has a potential for long-term vitamin deficiency, and you have high early complication rates. So the last surgery we're going to talk about is the adjustable gastric band surgery. This is also a one-step surgical procedure that involves placing a foreign object into the abdominal cavity around the upper portion of the stomach. The inflatable band creates a small stomach pouch superior to the band, with the rest of the stomach inferior to the band. The feeling of fullness depends on the size of the inflatable band and the size of the stomach pouch. So the band can be filled with a saline solution through a port that is placed under the skin. So the more saline solution in the band, the smaller the diameter, which limits the amount of food that can pass through during the digestion process. And increasing the band occurs slowly over time with what they call repeated fills. So eating just a small amount promotes a feeling of fullness, which lasts longer with a smaller diameter band, thus restricting food intake. And so this works because you have less food intake and less caloric intake, and this reduces hunger. And advantages include reduced hunger, induces weight loss, short hospital stay because it's a one-step surgery, it's reversible and adjustable, it has low complication rates, and you have no absorption deficiencies. The disadvantages include a slower weight loss and less weight loss compared to the other surgeries, and the foreign device must remain in your body. And there can be mechanical problems that arise with this inflatable band. And this surgery has the highest rate of reoperation compared to other surgeries.
So these are some medications for weight loss. And here are some more medications for weight loss. So now we'll talk about the PT management and implications. So for prevention, for primary prevention, we can encourage physical activity and healthy eating to prevent someone becoming overweight or obese. As secondary prevention, you can prescribe exercises that avoid high-impact activities to protect joints in people that are carrying excess weight. And as tertiary prevention, you can prescribe support stockings to prevent vascular insufficiency. So the effects that obesity has on the patient, it decreases their range of motion due to increased soft tissue. It can have muscle weakness and decreased aerobic endurance due to immobility. You can have increased musculoskeletal pain, slower gait speed in order to decrease the loading forces on joints, altered gait mechanics, decreased ability to balance on one leg, difficulty rising from the chair or floor, comorbidities, and risk for postoperative complications. So a PT intervention we can do is patient education, and so you can educate them on increased health risk from being overweight or obese, basic nutrition, importance of physical activity, and behavior modifications like walking for transportation, parking further away from buildings, and taking the stairs. So some strategies to facilitate successful exercise programs. This just follows the same principles as with healthy people. You can ask a patient about their current exercise routine, and you want to, instead of stressing weight loss, stress the health benefits of exercise. and you want to allow the patient to share their views on exercise, help the patient set goals, brainstorm ways to overcome barriers to exercise, provide written or pictures of an exercise program, and develop an exercise program that the person enjoys. And this may take some trial and error to find something the person likes. So an article that we found, it showed that an 8 to 10 week PT weight loss program decreased body weight, waist circumference, systolic blood pressure, diastolic blood pressure, and fasting blood glucose. And this program consisted of exercise, nutrition, and behavioral counseling. And this study is relevant because you should expect to see these changes when working with a patient if they are losing weight. And then also a drawback of this study is that it's difficult to generalize the outcomes because it's unknown which aspects of the program have the best impact for weight loss.
So PT interventions that you can use during working with patients that are obese or overweight, you want to make sure you include the warm-up and stretching, just like any exercise program. As they progress and become better fit, you want to increase the intensity, frequency, and duration as the patient can tolerate. Probably stick to increasing one at a time and not all the above. But mainly you need to focus on aerobic exercise. Try to do this most days of the week, and that means they typically do it at least 5 days. But the ACSM recommends that we accumulate a total of 60 minutes of formal exercise and daily physical activity. If they're able to do this 60 minutes every day of the week, that corresponds with 420 minutes of total exercise, which meets the recommendations for physical activity by the ACSM for promoting significant weight loss. We need more than originally thought in order to promote weight loss, and that is more than the 150 minutes recommended by the ACSM. We need to promote walking, moderate to high intensity, but circuit training is likely more helpful, whether it's on the stationary bike, in the water, or mixing in resistance training. Allow them to take short breaks, but keep their heart rate up in order to improve their aerobic capacity. So potential complications of obesity during exercise can present as the list as seen here. Typical angina can be normal during exercise, but we need to pay attention to other signs and symptoms that these people exhibit while we're training them. Be aware of just chronic pain due to ligament or joint problems, that those joints and ligaments have been stressed for a long period of time, so be aware of that. Make sure you monitor their blood pressure and heart rate, as those things can change quickly when training this population. So just make sure when we're using equipment, make sure that the patient can actually fit on the equipment, as that can be detrimental and embarrassing. We want to get them into the gym and have them exercise, and this will probably dissuade them from coming back. Make sure they're using proper body mechanics. They likely haven't exercised much throughout their life, so they might not know, and this can lead to more injuries. Make sure you plan your transfers and ask for help if you need it. A lot of these patients need more than one helper in order to allow them to be safe. And the most effective exercise protocol to improve cardiovascular fitness in overweight and obese subjects. This was a study done in 2017 by Castro and several others, and they assessed VO2 max pre and post test via the Bruce protocol. And this was intervention over 22 weeks. They split their subjects into 4 groups: strength, in which they mostly did resistance exercise, such as lunges, bench press, split squat, push press, endurance, and they were able to choose what type of exercise they wanted to do, whether it be treadmill, elliptical, or biking. And the strength and endurance group, which actually showed the biggest improvement in VO2 max and the most weight loss, was a combination of the previous mentioned, so they could do water, biking, elliptical, walking, and then they also were doing lunges, bench press, squatting, and the rowing machine. And then the final group was just a group that wasn't supervised, but they had to accumulate 150 minutes of aerobic activity a week. All the groups exhibited weight loss and increased cardiorespiratory fitness, but it does appear that prescribed exercise protocol is more effective than just general physical activity. Make sure to utilize a multidisciplinary approach with a nutritionist and exercise physiologist. With this study, we don't know if the caloric restrictions placed upon the patients, which was 25 to 30%, we don't know if that was more effective in leading to their weight loss or if the exercise interventions were more significant. This is a chart showing that supervised exercise led to more of an increase in VO2 max as compared with just general physical activity. And this also takes into account that BMI, a higher BMI is often associated with higher VO2 max, but when accounting for the weight and increase in weight, that VO2 max actually did increase and not just related to their higher BMIs. So as clinicians, think about using aerobic training between 50 and 60% heart rate reserve, and make sure when we strength train, focus on large muscle groups and try to work in that 15 rep max range. And a combination of these is likely more beneficial, and these should be done 3 times a week and in circuit form.
So here are our credits so you can see what everyone did and contributed to this project. And here are our references.